Okay, well, as Raj said, septoplasty is not easy. I'm glad he started with that, because one of the problems I think with septoplasty has been historically that it's kind of the number 2 operation that you aspire to when you're a trainee. You know, my recollection is starting out with as a first year resident learning tonsillectomy, grommets and adenoidectomy and things like that, doing a lot of assisting of surgery, and then the next level up is septoplasty. And then when you start into it, you suddenly realize it's really difficult, and it's really easy to make a mess of it and create holes and tears and all sorts of things. And what's made worse, unlike tonsillectomy, is it's not a spectator sport. So as Raj says, I've been teaching this kind of surgery for a long time, and I've formulated views, as you'll find all experienced trainees and trainers do with septoplasty. Everyone has their way of doing it. And I'm asking probably us all to take a step back and think about it more from an intellectual problem-solving theme, rather than sticking to dogma that we've been taught that we always do it this way. What I'm going to try and cover in a short time is relevant structure, clinical assessment, and probably the most important thing I think is going to be decision making, which is difficult. And because we're taught it in a prescribed way, and often you've got someone standing over your shoulder when you're making the decisions, but not actually to see what's actually being done. This is one of the difficult areas. And this, I'll quickly cover the surgical steps as well, more just for completeness. When we start learning septoplasty, this is the kind of picture we're given, isn't it? The quad cartilage and the bony septum, and our application is directed towards usually getting something that's bent straight, and that is the primary focus. But I think there's a lot more to it than that. The first thing I'd ask you, just to looking at the anatomy, just take a note of how much bone there is here. And one of the things we've learnt in the last 10, 15 years is that this bone is really useful. And I don't know if others were taught this way, but I was taught to consider this as being disposable, that you'd get in there with your tilly hinkles and you'd go and take it out and throw it away, because it was just in the way, part of the old SMR type philosophy. I never do that anymore. And if I'm needing tissue for a complicated septoplasty or a rhinoplasty, I'll take this out very carefully, often making cuts here and here to get it out in large pieces. And if I'm not using it, as long as it's reasonably straight, I'll always put it back. But the important anatomy and the money shot is not that one that we're all taught. It's actually this one here. This is what's important. What's important to know is that the septal cartilage is not just that. It's this. It's a complicated T-shaped structure that includes the upper laterals. They're all part of the one piece of business, and we shouldn't separate them. And that means that in many cases, when you're doing a septoplasty, you're actually doing a rhinoplasty as well. And good studies from the Netherlands have shown that the vast majority of septoplasties in the end will cause some minor cosmetic changes, because you're changing the major foundation of the soft lobule of the nose. And the critical fixation points, of course, are the nasal spine, where it attaches to the posterior septal angle here, and the keystone area that I'm sure Sandy will talk about later on. But it's a complex fibrous joint between the quad cartilage, the perpendicular plate in its septal part, and with the quad cartilages under the nasal bones and the frontal process of the maxilla. So it's complicated. And if you interfere with this, then the position of the anterior septal angle will change. The other thing to notice that we often forget is that the septal cartilage and quad cartilage, the upper laterals, are hyaline cartilage. They're not elastic cartilage, they're hyaline cartilage, and they fixate to the facial skeleton. Whereas the lower lateral cartilages that you see here, they're elastic cartilages. They're like the pinna, and they're soft and elastic, and they have no attachment, zero attachment to the facial bone. They rely on the septum very much for their floating position on the tip of the nose. What that means is that when you've got an anterior septal deformity, there very often will be associated abnormalities of the nares and perhaps more importantly, the tip. And this case shows very nicely about how a deformity of the caudal septum is having an effect on the whole shape of the nasal tip, which is underprojected and become bifid because of the fallback of the lower lateral cartilages. And that will be causing, that'll be one of the reasons for the nasal obstruction here, and that there's external valve collapse with that. And if we look at the way septoplasty is taught, certainly the way I was taught, it was very much a workmanlike approach. You know, there are these steps of the procedure that you do, and you do the same for everyone. And the other idea we were faced with when I was training was more space means better function. So the whole idea is to take as much furniture out as you can to create more space, possibly a bit of turbinate as well. Take all that annoying bone and bony spurs out of the back of the nose, and if you have to take some cartilage out, well and good. As long as it's straight, that's all that matters. So the focus has been on septal deviation rather than the cross-sectional area, and I'll explain why that's more important in a minute. That's not to say that if there is a gross septal deviation, which often these are the cases that we're doing these days, they're people with major deformity, as you see here, that is going to be the cause of the nasal obstruction, and of course you're going to focus on that. But for the slightly more subtle cases, the main effect of flow restriction is on the nasal valve, and you can see from these inspiratory flow maps how nasal flow is highest velocity through the area of least cross-sectional area, which is the nasal valve. And this is the area where the nose stresses the most. This is where people get crusting and bleeding, and it's all because of the high flow. So that minor changes here will have a big impact on flow restriction. But that's not just the deviation of the septum. We're also looking at, or should be looking at, things like valve height, height of the septum, configuration of the inferior turbinate, but and also the upper laterals. What do I mean by the valve? What do I mean by the valve? Well, the valve's actually a three-dimensional space. It's not, we talk about cross-sectional area, but it's a three-dimensional space. It's got depth. Eugene Kern described it rather nicely as a teardrop-shaped three-dimensional space. You can also almost imagine a teardrop and put that in there, and you'll see the teardrops created by the upper lateral, the septum. So the septum is important, the inferior turbinate, and the lower part of the piriform aperture. That's the internal valve, and obviously the external valve anterior to that will have an effect as well. So what I'm saying is we shouldn't just think about the septum, we should think about the application that the effect we're having on the cross-sectional area, particularly in the internal valve. That's the important thing. And what that means is that although it's tempting to take out bent bits and make it look nice and straight, which is kind of a carpenter's approach, it doesn't necessarily mean that the function is going to be better. And in fact, you can make it worse. And I'm sure we've seen lots of cases of patients that have had septoplasty. You see them back in the clinic. The septum looks straighter, but the patient says, oh, actually, it's no better. If anything, it's worse. And I think very often these are not just perceptive problems from the part of the patient, but actually the fact that we haven't addressed the problem of improving the cross-sectional area. So that means at times our assessments not good enough. And it isn't good enough just to say, oh, well, you've got a deviated septum, so what we're going to do is we're going to do a septoplasty. I think we probably need to try and be more exacting in the assessment of the nose and nasal airway. I think we probably are now. Almost every patient, if not every patient, will get a nasendoscopy. We will be palpating the external nose, as you see here, having a feel about the structural integrity of the cartilage, which is a bit difficult to get a good idea of until you're actually in there performing the septoplasty. But the structural integrity of the septal cartilage itself will vary and is often weaker in females, and that can be an added cause for collapse and an added cause for septoplasty failure and saddle deformity afterwards. So we need to work out where is the deviation, is it relevant or not. Deviation posterior to the nasal valve area very often isn't that relevant. Is there any associated external deformity? In which case, you know, do we need to address that or not? Is the external deformity having any functional aspect if it's affecting the upper laterals? And perhaps equally important, is there any associated pathology? Rhinitis in particular, especially an older patient who's on antihypertensives and maybe had an injury at football when they're a teenager and they're pitching up at age 55 saying, oh, I've got a blocked nose and I had this injury all those years ago. And we're asking the question, well, why are you coming now? You know, the injury was, you know, 30 years ago. And then I don't know about you, Raj, but I see cases that they don't quite add up. I think that's the best way to put it. The decision making is difficult because there is a septal deviation, but the patient's symptoms seem excessive compared with the deformity that's there. And there are some situations where you're just not sure if the septal deformity is relevant or not. And I think that's where investigation can help, and airway testing has its place with whatever airway test you have available, whether it's peak flow, peak nasal inspiratory flow, or if you're lucky enough to have rhinomanometry and rhinometry. They can give you a useful bit of added information. And then if you're not sure, it's always a good idea to ask a colleague for a second opinion. I don't know about you, but I have certainly seen cases that I've seen myself like 3 months later and not realized I'd seen them before, and looked at the patient and thought, why on earth has this patient been put on the list, and realized I've listed them myself. So even the test there's definitely some intra-observer error there on my part, I'm sure, especially when you're talking about borderline cases. We're not talking about a barn door case here. And as I alluded to before, it's a good idea to ask the question, why does this patient want to have this done? And obviously, if it's a barn door case and there's a gross deviation, you don't need to ask the question. But if you've got someone elderly coming along wanting the deformity that occurred when they were a teenager fixed, you should be asking the question, why now? And are the expectations realistic? In my experience, operating on someone who has added pathology such as vasomotor rhinitis, especially if they're older, and I don't mean to be ageist about this, the outcomes tend to be more disappointing. And then we've got to be aware of the patient that is the background to the reason they're presenting is more cosmetic rather than functional, and they may be pretending there's a functional problem. And that's where, if in doubt, more than one consultation is probably a good idea, rather than making rapid decisions. That gives you a better idea whether the patient's expectations are realistic and consistent. Moving on quickly to actually planning the surgery itself. We're not talking about there are lots of other questions that you would ask, you know, about associated pathology. Assuming that's all been done and you're in the zone where this patient does justify surgical correction. it's a good idea before you actually list the patient to have a think about what kind of septoplasty is required. The first question I ask is, will a simple mobilization septoplasty be enough? And what we need to know is, firstly, is the deformity simple or complex? If you're dealing with a complex deformity like a severe caudal deviation or an anterior component severe fracture, the reality is that a mobilization septoplasty is probably not going to work, because you're still going to have the deformity there afterwards, in my experience.
Oh, just a quick question.
Yeah.
A columella pocket in this situation, that photograph on the left?
Yeah, I've tried them.
Popular, aren't they?
Yeah,
popular.
they're popular. I've tried them. In my experience, the long-term results for severe caudal dislocation are not good. And I was taught to do them. I've done them myself. And when I do them and see the patient on the table, I have a warm feeling inside because it looks like it's worked. But then too often I see them back 3 months later and the caudal dislocations recurred. And it's made me think, this is not such a good strategy, all due respect. The reason being that the hyaline cartilage of the nasal septum has shape memory and it's fixed to the nasal skeleton. And when you're creating a columellar pocket, you're creating a pocket between the two medial crura in the skin envelope of the membranous septum, which is mobile and has no fixation anywhere. It floats over the septum. So while at operation, you can distort things a bit and reposition this soft pocket, the reality is that that pocket will eventually move towards where the fixed shape memory of the caudal dislocation. So I tend to be a lot more radical with these now, and I would excision and reconstruct some kind of limited extracorporeal, which I'll explain in a minute, just because of this shape memory issue. Obviously in a mild case, it may work, but with a severe case, I don't think so. And then still talking about mobilization septoplasty, try not to burn any bridges. So that let's say you're in a situation where you've listed the patient for a mobilization septoplasty, you've freed up the quad cartilage, you've done a posterior chondrotomy, and it still doesn't look right. You think, well, I'm just going to have to take more stuff out. And if you take more cartilage out and bone out, and you don't put it back, you're burning bridges for that person. And I've done it. You know, we were taught to do it that way. And I don't do that anymore. I think you've got to be responsible and think, well, if this may not work, this mobilization septoplasty, that's not the end of the world. You know, we can come back on another day if we need to, or perhaps it will work. But certainly, we don't want to throw tissue away. It's important that we. Sorry about that. It's important that we're responsible for the patient's needs. So down cartilage resection and avoid burning bridges. And the other questions are really much simpler than that. Is it going to be a closed or open approach that you're going to use? An open approach is only really justifiable if it's a very severe deformity, particularly affecting the anterior septal cartilage, and especially if there are cosmetic issues as well. Does the patient have significant cosmetic issues? That's going to open up a whole can of worms in terms of getting psychological assessment, but it's better to do it in one go if the patient really does need it. I don't think it's ethical to do a septoplasty and the patient comes back and then you have to consider a second procedure that involves opening the nose up again. And also, have you got enough tissue? If the nose is under-projected and the septal cartilage is badly bashed up, you do your nasendoscopy and you have a feel with a Jobson horn probe and find there's not so much cartilage there, you're going to know beforehand that a simple mobilization septoplasty ain't going to work. These are the steps that we advocate, and I must admit, for 20 years, I never thought about the steps because it really was a workmanlike approach. You just do this each stage. But if you break it down, you've got an access part where you're focusing on getting your flaps up without tearing them. Prior to that, pre-injection, obviously. Then you could do mobilization, which will involve limited chondrotomies, and then some kind of reconstruction. And it's stage 2 and 3 where all decision-making comes. I'm going to quickly go through this part because I'm aware we're short of time, and I don't want to teach you how to suck eggs. I mean, obviously you know about pre-injection. I think the key for pre-injection for me is giving it time. And I have worked in some institutions where pre-injection's done after you've scrubbed on the table, and I've never thought that was a very good idea. It's a good idea to pre-inject before you go and scrub, and that gives time for the adrenaline to work. Incisions, standard incisions are hemitransfixion these days, but of course we're using a modified Killian's, probably for doing endoscopic septoplasty. Mucoperichondrial elevation. The faults I've seen with trainees is they've struggled to get the mucoperiostome off the voma here, and they may only go this far. And I think you kind of need to develop your technique. You need to try and really be able to get right down over the voma here. And that means going into a different plane and using the equivalent of Cottle's tunnels. Otherwise, this is the area you're more inclined to get tears. And I think it's often because of poor technique elevating the mucoperiostome there. No problem about doing your posterior chondrotomy, and limited cartilage resection if you've got a quad cartilage that's too long. I think these are pretty standard things to do. Probably wouldn't throw that away now. I'd put it back in some way, and I wouldn't resect bone much unless there was a need to. But certainly, if you're doing some kind of augmentation, as we said before, this bone's really useful. And you can take the bone all the way back to the sphenoid if you want to. Adjunctive procedures, these are very popular. But once you've done a mobilization, you need to make a decision about where you go from here, whether it's just going to be adjunctive procedures, which you probably will do with a mobilization, or whether you're going to do any grafting. And with an open approach, you've got a lot more opportunity to do different kinds of graft, whether it's a septal extension graft or a full extracorporeal. These things are pretty standard, aren't they? Cut the fracture line out, and there's lots written about figure of 8 sutures, which I've never been able to make work very well, and they don't necessarily give you a stable quad cartilage. I think this works better. You take a bit of cartilage out and you can put it on, and you can do lamination to improve your valve height and anterior projection. With a mobilization approach,
well, just a couple of questions seem to be about difficulties in raising flaps. Okay, so not getting in the right plane, so ending up between perichondrium and mucosa. And if you're in the wrong plane in one side, should you try and retrieve the situation or work harder on the opposite side to try and get in the right plane, risking a tear? Yeah, what's your thoughts on that?
The first thing, for reassurance, it's difficult. What I was never taught is that the way that the distal caudal perichondrium decussates into the cartilage, which is why we always find doing a hemitransfixion, or nearly always, that it's really difficult to get in the right plane. I think these are all technique issues, and they have to be taught well at the start. And if you're not taught it well in the start, you'll end up with surgeons often being in the wrong plane, which just creates huge difficulty. You get more bleeding, you're more likely to get tears. I think you need to do sharp dissection to get into the right plane. That's the key. And if you're in the wrong plane, you're in the wrong plane. You need to get into the right plane. And if you can't get into the right plane, someone needs to help you and show you why. If you've got the right instruments, I use scissors a lot, actually. I do little spreads and snipping. to get into the right plane. I think that's the bottom line. I'm not sure, you know, if you're not in the right plane, go to the other side, maybe, if it's a very traumatized septum, because there can be cases that are a nightmare where you've got a lot of subperichondrial scarring.
Agreed. You've got to, you have to pause, right? You have to pause and then try and get into the right plane, even if it's a little bit further back, because invariably you will make a hole in the mucosa if you're not in the right plane.
Yep.
Okay. Thanks.
And wide approach, getting down onto the bone is also helpful.
Okay.
Adjunctive measures, I haven't got much good to say about these, really. I think cartilage shaving, sure, if the cartilage is very strong, but scoring doesn't do it for me. And it's back to thinking about the anatomy. It's hyaline cartilage. It doesn't have elastin in it. So it's not going to be like a pinner. When you do a pinoplasty in an under 5-year-old, the cartilage will curl in front of your eyes, but hyaline cartilage, all you're doing is weakening it. So my worry is there's real potential for burning bridges, and that these diagrams look lovely, but in practice they cause weakening, and that will affect valve height and be a potential for collapse. Extracorporeal septoplasty, popular, risky, difficult, and not a thing to be doing first up. I think it's a minority of septoplasties that you should do this on. I do a lot of them, but then my work practice is not typical. I've seen probably more complex cases and revisions. The problem being that it's technically difficult. It's great once you've learned how to do it, but it takes years. And there are real risks of complications of saddle deformity with it. And this kind of thing that you're seeing now is not easy. Getting that interosseous suture into the nasal spine is technically a difficult thing to do, and it will vary on where the spine position is. So many things that can go wrong. That's not to say you shouldn't do it, but it's more a specialist operation, I think. And when it works really well. And there's a good example of a caudal dislocation done by an extracorporeal. We've just flipped the cartilage. Caudal dislocation before. We didn't do a columellar pocket. We did, and you can see good position and a good functional result. But there, of course, there are other options. It gives you the possibility, if you've got poor projection, which will have an effect on breathing, and poor valve height. If you've got a stable base, you can take some of the cartilage out at the back and build on at the front. And I have no problem about laminating. I mean, some people say to me, well, lamination, you're making the septum thicker, you know, and that you're going to affect the airway. Well, it's often not relevant, especially in someone who's got thin, weak cartilage. It needs to be stronger, and you need to get that valve height up. One or two very key points, finally: post-op care, drain holes important, and you often find the more experienced trainees, ST 5 and 6, have patients coming back with septal hematoma, and it's just because they've got much better at doing the septoplasty, and haven't done any tears, so they're more likely to get septal hematoma. Post-op care, don't use antibiotics. Douching is important, and I do use splints as anything done to the lateral wall. And of course, complications, the ones to worry about: septal hematoma, adhesion, saddle deformity, and perforation. And a lot of this is due to poor technique, I think. Exacting technique and exacting assessment, and you shouldn't have problems. So my final thoughts are, exacting assessment is the key. Time and reconnaissance is seldom wasted. And when you're planning your operation, the first question to ask yourself is, will a mobilisation septoplasty actually be enough? And if you're trapped in a situation where someone else has listed the patient for the operation, for goodness sake, don't burn any bridges. No one ever suffered from having a septoplasty that didn't work particularly well, particularly if all of the furniture's been left behind in the house. Thanks.
Thank you, Paul. That was very comprehensive. Thank you. In terms of the difficulties with making decisions, I think that's probably the take-home message, is that What is a successful outcome? A happy patient with better airflow, that you haven't cosmetically changed their nose, and that you don't have to revise. Right?
Exactly.
And I think we need to get away from that. You know, if it doesn't go right the first time, then at least we've got a revision operation to fall back on. So that's really, really helpful. Okay, so no additional questions from the audience. Thank you, Paul. I appreciate it.
Pleasure.